Bueno, buenas tardes. La verdad que es un placer para nosotros hoy hacer esta tercera reunión del ciclo de conferencias de los sanatorios de la Trinidad, que le queremos agradecer el apoyo a AVI y el auspicio de Fundasamín. Hoy iba a coordinar el doctor Di Gregorio, que por temas de electrónica compleja no ha logrado conectarse, de manera que me toca reemplazarlo por lo menos un ratito, y me toca una tarea terriblemente difícil, porque presentar al doctor Jobe no es una tarea fácil. Alan es primero, si yo tuviera que decir algo, tengo que decir que además de ser un neonatólogo brillante, uno de los líderes más importantes de la neonatología de todos los tiempos, particularmente en el área de enfermedades respiratorias, pero no solamente en ese área, es una gran persona, es un tipo increíble. Nos ha apoyado a Luis Pruden y a mí y a la Fundación como muy poca gente. Vino voluntariamente varias veces, nos apoyó desde todo punto de vista en múltiples proyectos, y es un investigador que ha contribuido enormemente a los conocimientos neonatológicos, desde la investigación básica a la investigación clínica y a muchos aspectos prácticos que realmente fueron extremadamente importantes. De manera que hoy va a tomar un tema que a mí, a Cecilia García y a mí nos fascinó cuando lo vimos presentado, no exactamente la misma conferencia, pero presentado relativamente en Hot Topics in Neonatology en 2018, nos dejó impactados porque lo primero era la sensación que teníamos todos de qué ignorantes que éramos, de que algo tan bueno como los corticoides prenatales pueda en realidad no ser tan perfecto. Entonces, él, estoy seguro que hoy nos va a hacer reflexionar sobre muchos aspectos de los corticoides prenatales que podemos conocer y otros que no conocemos tan bien. Y luego de eso vamos a tener primero un panel reactivo de lujo, con dos obstetras y un neonatólogo, el doctor Lucas Otaño, la doctora Andrea del Carreto y el doctor José Díaz Roselo, que nos van a ayudar con algún comentario y alguna pregunta. Después los vamos a presentar a ellos cuando les demos la palabra. Pero sin más, vamos a escuchar y ver la conferencia del doctor Jobe. Así que, Alan, adelante.
Okay. Well, good afternoon. This is Alan Jobe from Cincinnati Children's, and I want to give you a talk about what neonatologists should know about steroids. The problem with steroids is all the decisions about antenatal steroids are made by the obstetricians, for better or worse. And so we as neonatologists are just getting any collateral damage from that. So I want to talk a little bit about what that damage might be, and also about some things that we've learned recently about what these steroids actually can and can't do. All right. So my conflict of interests are minimal for this topic, because the work I've been doing with antenatal steroids is actually for the Gates Foundation, trying to come up with a lower dose. So, and I have no funding for this other than the Gates Foundation. That funding's also done. So my goals are to appreciate that preterms have IQ deficits, and acknowledge we do not understand the causes. Talk a little bit about the differences in the drugs and effects on the newborn, and how the DOHID concepts may be unavoidable because of bad effects that we cannot fix with our therapies, and then suggestions about antenatal steroid dosing. Okay, so let's talk about our preterm infants. This is also part of a talk called How Trying to Make Better Babies that I'll be giving for Eduardo Boncalari at his thing, and I think you're going to also show this. This same audience will have access to that talk. So you'll see some of these slides again. This is my sketch of what we have with normal, with preterm infants. we have a normal IQ distribution for our normal deliveries. For our very preterm infants, we actually know, and I'll show you a little data, that there's about a half a standard deviation downscale deficit in their mean IQ. And then there are two other problems on the curve. One is this big shoulder out there, where we have modestly low IQs in a large number of babies. And then there's that little bump at the bottom. And that's for the really devastated babies that have had multiple injuries. So those are three regions that we can try to think about how we could make better babies and how steroids might interact with that. These are reasonably recent data. It's a meta-regression. So each circle represents a different study. And the intercept on that is about 1/2 of a standard deviation below 0, which means these babies are taking a 10 to 15 point IQ hit because they're very preterm infants. And the interesting thing about this is this curve has the same slope from 1990 to 2010. So we're not making better babies over the last 20 years. We get the same outcomes for our tiny preterm infants. There's probably just more of them surviving. So this is the curve for BPD. So this is, on the x-axis is the percent of BPD in your particular population, or in the population you're doing follow-up on. And basically what you see is that as you have more and more BPD, you have worse and worse neurodevelopmental outcomes in terms of IQ. And these are reasonably recent data as well. So there's two problems. First of all, severe prematurity, and then BPD is a confounder. These are data from Canada. They're population-based data for Canada for using billing to look at outcomes in terms of audiometry or other neurocognitive things. So these are kids who've been seen by somebody who's billed for their service in Canada. So these are the infants that were exposed to antenatal steroids, but delivered at term. And I'm going to talk a lot about this group of babies. So let's make this very clear. So it turns out that about 50% of the babies treated between 24 and 34 weeks gestational age appropriately because of a concern about antenatal steroids actually don't deliver in that interval. And a bunch of them don't deliver until term. And if they deliver at term, they have more problems with hearing and more other general neurocognitive disorder problems if they've been delivered at term. So that's a late effect of the early gestational exposure to antenatal steroids. This is really a concept that nobody's even looked at before. So this is another recent paper looking at the deficits in birth weight and head circumference in infants who were either term, so that's the control group, or there were near term, or they were preterm. These are all babies exposed to antenatal steroids. So if they were preterm, they have an effect on their birth weight. And if they're a near term, 34 to 37 week, there's still an effect on their birth weight. And at term, there's still a discernible effect on birth weight. These are studies for all of Finland over a period of 15 years. And head circumference also takes a hit with antenatal steroids if you're preterm or you're near term or you're born at term and exposed to antenatal steroids. So all those things are a biological plausibility about why these kids won't do as well. They have a weight deficit, they have a head circumference deficit. This is the thing that Nestor and I were talking about before I started this talk. This is a remarkable study of 670,000 deliveries in Finland. It's a Finnish birth cohort from 2006 to 2017. Now in Finland, they capture by their government healthcare system every kid and do extensive neurodevelopmental follow-up for them for a number of years. So these kids are at an average age of trying to read through this quickly. I think they're about 6 or 8 years of age. I'll have to look that up. You can look up the article. But the problem is the entire cohort, there's no benefit of antenatal steroids. So the second line is term deliveries after exposure to antenatal steroids. So they have a bigger deficit in their neurodevelopmental behavior assessment. And the entire that's a part of that entire cohort group. And then if you're preterm, this is what's quite interesting. There's been a lot of studies that show if you're preterm and get antenatal steroids, you don't have obvious neurodevelopmental bad outcomes. So in this population, the same thing occurs. So what this really means is if you're born preterm and you get antenatal steroids, you don't have a neurodevelopmental hit because of the other benefits of the steroids. But if you go to term and then delivery, you do have a hit. So that's, I think, a real problem for us, because particularly in Argentina, if people are giving steroids to women who are delivering by C-section, then the majority of your kids are going to have problems because they're going to be exposed to steroids, because a lot of people are actually treating women for elective sections with antenatal steroids. This is looking at the lung, which is, I think, also a problem. So these are the alveolarization numbers based on gestation, as best we know them. For the normal lung, the severe BPD probably isn't that low, so that's probably an exaggeration. For the normal lung, there's two curves. There's this curve. This is the normal one. This is Nestor and I. We're falling off the curve because of our age. This is perhaps our preterm infants. So I want to show you a little bit. But this, I think, is also a real concern. So a number of people have developed the concept and tracked kids up to 36 years, doing pulmonary function within the first year of life, and then tracking them at later in life. And then these are tracked at 16 years and at 22 years. And there's data out to 36 years now. So kids who start with a good FEV1, which is really a measurement of small airway disease, have lungs that preserve function much better into old age as you age. There's other categories of babies who have when they're born, lungs that don't perform as well as these. And then there's these low performers down here. So it turns out that if you're a preterm, with or without BPD, this isn't the slide I want. I'm going to go one more slide. Sorry about this. There should be another slide in here. It's vanished. So these are outcomes for preterm infants, which I want to. So this is also a buried outcome. It turns out if you just do blood pressure on preterm infants, they tend to be higher than they are for term infants. And it turns out that they're not very different. But if you do a special test, an augmentation index to measure central blood pressure, these kids that are extremely preterm have elevated central blood pressures. There's also, so this is an outcome at 19 years of age of kids that were born in 1995 in the UK at less than 26 weeks of age. So these kids have elevated central blood pressure, even though they're peripheral. So if you're the pediatrician taking their blood pressure, it's probably going to be normal. It's just that their central blood pressure is abnormal. This is something that's even more distressing that was just published. And that's particularly for us that are male, that our telomere lengths, if we're born preterm, are shorter than they are for term kids. And telomere lengths imply aging. This applies really to men, not to term men, not to term preterm men rather than preterm women. So again, the boys do worse than the girls for mortality and telomere length. And so if you put together the lungs, the neurodevelopment, and the the telomeres, basically what you come up with is the concept that when you're at term as an ex-preterm, you're actually about 15 years old. You've already aged considerably, which means as you're going to age out, you're going to get more diseases of aging. This is another concept slide that Barbara Schmidt put together. So these are the probability of poor developmental outcomes at 18 months. If you have, if you're normal, you have BPD, have brain injury, or have ROP. So I think this is a really powerful curve to keep in mind. So if you're a normal preemie, you actually only have a 20% probability of a poor outcome. But it turns out the more hits you take from the diseases of prematurity, the worse you get. So if you're up here after 3 adverse effects, this is IVH. You actually have an incredibly high rate of having a bad outcome. So the one thing we can do to make our babies better is to make sure they don't get injured. So how to make babies better? Avoid injury, to avoid the developmental origins of health and disease effects. Avoid prematurity if you can. We don't know how to do that. So the summary of outcomes: prematurity plus or minus antenatal steroids may cause early aging to the preterm, and I have data on the heart as well. The DOHAD concepts basically induce a metabolic syndrome in our preterm infants that has implications for diabetes and heart disease in later life. We have no clue how to avoid these other than to prevent prematurity. And we could minimize our exposure to antenatal steroids. It would probably benefit everybody. So the big overview here is that there are preconceptional factors. The biggest one that we know about that's consistent throughout all the studies is maternal smoking. Then there are gestational age effects, gestation effects, growth and that sort of stuff. And then there are postnatal effects. And then we have outcomes for either the heart, the lung, or neurodevelopment. And the problem is there's too many of these. We don't know how to control them. Okay, now I'm going to talk almost entirely about steroids. This is my concept slide for every neonatologist who's taking care of babies. And that is that almost all of our babies that are very preterm have been exposed to antenatal steroids. And then these very, very preterm babies often has low blood pressure. And there's actually a move now to treat them all with hydrocortisone. I'll talk a little bit about that. So they get steroids again, and then they get postnatal injury and BPD, and they get more steroids. And then with lung repair and remodeling as an outpatient, they get more steroids. So each exposure can increase or decrease lung function. Each exposure is a time-dependent and dose-dependent effect. And we, as clinicians, think about our use of steroids individually for each exposure, be it for a blood pressure problem in the early days of life or for BPD, but we don't actually integrate the concept how much steroids this kid has actually been exposed to. And that actually may be the predictor. The area under the curve for all the exposures may be what we actually need to be thinking about. So there's different drugs for antenatal treatment. In Argentina, you're probably using predominantly celestone, which is a mixture of betamethasone, 12 milligrams, given twice. And it's a mixture of 2 drugs, betamethasone phosphate and betamethasone acetate. I'm going to talk about that. The WHO recommends for antenatal steroids basically 4 doses of dexamethasone because it's cheaper, more stable, and more readily available. And then for postnatal use, we use dexphosphate or hydrocortisone. We don't use betamethasone. So this is just something about the adrenals that is in a review by Bond and Waterberg, which is worth reading. It's a good summary. Characteristics of adrenal function in newborns. First of all, fetal cortisol levels are extremely low in our very preterm infants at birth. Cortisol synthesis begins after about 30 weeks gestation in these preterm infants. So these preterms are, by definition, adrenally insufficient at birth. do they do better when treated with low-dose steroids? And again, there's a discussion of treating all these kids with low-dose hydrocortisone, not dexamethasone. Antenatal steroids pharmacology is actually really complicated because we're treating the mother to treat the fetus. So it turns out if you look around the world, people are using variable doses and routes of treatment. There's some people that give this IV, which is really a bad idea. And then there's the issue of placental transfer. And then there's clearance from the mother. And then there's clearance from the fetus. And we have some data on that from sheep and from humans. And it seems to be that it's very slow. And I'm going to talk about that a little bit more. So what is the effective exposure on the outcome that we're interested in, which is really RDS, IVH, or death? It turns out that we don't know. The doses that we're using were actually proposed by Liggins in 1972, and nobody's ever done dose-finding studies on this. So this is something that nobody talks about much to mothers when they're consenting them to give them steroids. It turns out, depending on what outcome you're interested in, the steroids have effects at different times. So if you're trying to prevent death, the really effective interval is if your delivery is less than 24 hours or less than 48 hours. There's probably some effect at 1 to 7 days. But after 7 days, you lose that effect. For respiratory distress syndrome, it seems that in sheep, you have an effect within 24 hours. But the big effect in humans is between 48 hours and 7 days, and you lose the effect after 7 days. For interventricular hemorrhage, it's much more narrow interval, from 24 hours to 48 hours. So the point is that we talk about steroids having a global effect, but it turns out that it's time dependent in terms of what effect you're going to likely get. So these are data that aren't actually published in this format. There's some NICHD data I've gotten my hands on. So these are cord blood values from women who received antenatal steroids. So the arrow out there is for 6.5 days after the second treatment. So these are cord blood levels. So a couple of points. I don't know if my arrow shows or not, but these values are very high. So presumably these women got their 24-hour dose and then delivered. So it might have been an hour later or something. Their cord blood levels are 40 and almost 45 nanograms per milliliter. But it turns out at 6 days of age, the cord blood levels are still about 5 nanograms per milliliter. Remember that number. These are the maternal beta-methazoid levels. And these curves look very similar. So the mother still has, and I'll show you data for this in humans, that you can measure beta-methazone in the maternal circulation for 2 weeks, which is, I think, frightening. So this is the ratio of fetal to maternal. So the ratio is about 0.4 at early times, but at late times, it gets closer to 1 because these things have come to equilibrium. So these are even newer data that were just published of a French study looking at cord blood levels of beta-methazone after 2 doses of, these are maternal plasma levels. So they're in the range of 50 nanograms per milliliter. And then they taper off, and at 3 to 4 days, they're still 4 nanograms per milliliter. This is cord blood, again. And the peak here is about 20 nanograms per milliliter. And this is out at 3 to 4 days. It's still about 4 nanograms per milliliter. So what does that really mean? It seems to me that there's something we haven't thought about, and that's that when you get a baby who's been treated with antenatal steroids, most of their deliveries are going to be in this interval. They'll be at 2 days. And so their blood level will be about 10 nanograms per milliliter, which is actually a big slug of beta-methazone. So when your baby's born, the baby's already under steroid treatment, okay? And this stuff is actually cleared slowly. So I think you have to consider when you have a baby that's gotten antenatal steroids, you have to think about the timing of the second dose because that baby still is under treatment. And we haven't really thought about that before. I'm wearing this mask because I don't want to catch COVID like our president did. So these are data from India. We did a study on non-pregnant, healthy women with normal BMIs that we gave the clinical drug to. We gave either 6 milligrams of dex phosphate, IM or PO, 6 milligrams of beta phosphate, either 3 milligrams of 6 milligrams, pardon me, of dex phosphate, either IM or PO, or 6 milligrams of the clinical drug, celestone. That's the mixture of the two drugs. So these drugs are cleared relatively rapidly. The beta phosphate is perhaps a better choice because it's cleared more slowly than dex. It turns out that we don't even have a beta phosphate prep available in the US. And it turns out the clearance is identical for oral or IM. These are levels made 11 days after the second dose. You can still measure levels in the maternal circulation. So the baby's being treated out to almost 2 weeks. So I think that's really a problem. So this is the effect of these treatments with celestone versus betamethasone versus dex on the maternal. So this is the circadian rhythm. So you wonder why you sleep through seminars after lunch. That's what happens to your cortisol. This is 3 in the afternoon. You have a really low cortisol level. So it's back up to 70 in the morning. And then if you give these women steroids, you just trash their cortisol levels. And this is the celestone at 72 hours. It's still completely suppressed. It's actually very suppressed out to 4 days. So when we're using clinical treatments, what we're doing is we're doing this to our maternal cortisols. And then at 24 hours here, we give them a second dose. So we shift this curve again. So our women sitting on labor and delivery who are getting antenatal steroids are adrenally suppressed. So nobody's really reporting much in terms of increased infection. But I think it's a theoretical problem that our women are actually very suppressed if we're giving them the 2 doses of celestone. And then if you repeat your dose, the woman is permanently suppressed for weeks. So that's probably a bad idea too. So this is another measurement. It turns out that their white cells, their lymphocytes are also screwed up, as are their basophils and their neutrophils. So giving steroids to these women really messes them up metabolically, as their glucose also goes up. These are studies we did a few years ago to try to start to understand how much steroid you actually need to accomplish lung maturation. So this is the clinical dose. 0.25 milligrams per kilogram times 2 is what we're doing to our women. And so these are sheep treated with either that or half that dose of the beta acetate alone. So no beta phosphate, just beta acetate. So it's actually 1/4 of the dose. And it turns out in their pressure volume curves and their compliance measurements, this is the control. It doesn't matter if you're using the clinical dose or you're using 1/4 of the clinical dose. You get the same benefit. So that told us that we don't need such high doses. So in the rhesus macaque, these are monkey studies, it's the same phenomenon. If you use this low dose, you get lung maturation. A lower dose of 0.06 doesn't seem to work. Therefore, lung maturation does not require high peak blood levels in the fetus or the mother, or fetal levels. So I'll talk a little bit. These are the actual curves. So this is primate maternal. So this is the clinical dose, and this is half the clinical dose actually. This is beta acetate alone in the fetus, and this is the cord blood level in the fetus. Pardon me, this is beta acetate in the mother, and this is beta acetate in non-pregnant monkeys, where we could do more sampling. So this is pregnant monkeys, beta acetate. very low levels in the mother, just over 2 nanograms per milliliter. And these are the levels in the fetus that cause lung maturation. It's about 1 nanogram per milliliter. So it's really low level. So these are the pressure volume curves. This is sort of what I showed you already. This is the beta acetate. This is the beta acetate that's a lower dose. And this is measurements of surfactant. So this low dose of beta acetate, if anything, gives you more surfactant. So these are sheep levels. These are beta acetate levels in the mother and in the fetus. Pardon me, this is the sheep, and these are fetal levels. And this is beta acetate, beta phosphate. This is beta in the fetus, and this is in the rhesus and in the sheep. So these are really low levels that are causing lung maturation. So beta and dex are equivalent except for the PK. We have data to say these drugs are equivalent in terms of their if you like, bio behavior. Blood levels are proportionate to dose. The minimum dose, assuming anti-inflammatory effects that have some effects for lung maturation with steroids, would be 8 doses of 0.15 milligrams of dex for a 12 milligram total dose would be one way to treat women. When we give, I'll skip that. Okay, so these are different dosing schemes that you might use to treat these women. This is another interesting phenomena. We've been this has actually been resubmitted after revision. So it's about, if we give women betamethasone acetate, this is the lung maturation response we give them. If we expose them to intraamniotic inflammation with LPS, we also get lung maturation. If we expose them to both agents, we get better lung maturation. And this is the surfactant. Steroids alone, inflammation, the combination. So there's really 2 pathways to lung maturation. So there's some questions that need to be answered to try to understand what's going on. Another thing that I don't think we tell women when we consent them is that only about 40% of their fetuses seem to respond. So which means 60% of the babies that get steroids still get RDS. So it doesn't work in all fetuses. It doesn't work in all animal models either. LPS inflammation causes a much more consistent response. So we need to know what triggers the inflammatory maturational signal, because we get 100% response if we give them an inflammatory stimulus. So I'll show you a few issues about targeting antenatal steroids to treat who benefits. So if we were doing this like we were treating a cancer victim, what you would do is you would diagnose the cancer and then you treat the cancer. But we're diagnosed women who might have preterm labor or something else, giving them steroids, and a bunch of them don't. So most of the women we treat actually have no benefit from antenatal steroids. And there's probably no rationale for giving repeated exposures because of the long exposure of the drug we're using. And we can use a much lower dose. So why do only 40% of the fetuses respond to lung maturation? It could be because there's differential exposure of the different fetuses that could result from the maternal blood level, placental transfer, fetal blood level, or clearance phenomena. So you have really different drug exposures, or there could be a biological difference in maturation in the lung of the fetus. We don't really know what it is. So we did an experiment. I think this is in press in the American Journal of OBGYN. We gave 10 maternal fetal pairs saline placebo. We gave 20 maternal fetal pairs betamethasone acetate plus phosphate, like we were treating women. We measured maternal and fetal blood levels in catheterized fetuses, and then we took different animals and delivered them for lung maturation studies. So we're calibrating their response or no response based on their CO2 response with 30 minutes of mechanical ventilation. So we treat the mother, which is treating the fetus, then we deliver the fetus and we ventilate the fetus and see what's going on. So the fetuses that respond have a better pH, a lower PCO2, a better PaO2, a lower heart rate, and a lower blood pressure, probably because they're not as sick on the mechanical ventilator. It turns out that the plasma levels in the mother or free blood drug levels are absolutely identical in the mother and in the fetus for the responders and the non-responders, which really means that there's some reason that the fetus is intrinsically not responding to the steroids because they're seeing the drug. What this means, and we've done another experiment, that giving them more steroids isn't going to help. So more steroids won't help. These are responders versus non-responders for total betamethasone and free drug. It turns out the lung is probably responding to the free drug because the rest of it's protein bound. So the responders and the responders have really identical blood levels. So it's not the steroid level that's giving you different responses at all. So many women exposed to antenatal steroids do not benefit. The fetuses, if you think about it, before antenatal steroids, the occurrence of RDS in a 34-weeker is actually relatively unusual, as it is in a 33-weeker or a 32-weeker. So most of these babies don't benefit from steroids. Are there opportunities to identify and treat pregnancies that will benefit? Well, these are some studies I've done with a couple of people here at Cincinnati, looking at different organ systems by profiling mRNA in the amniotic fluid. So there's specific gene expression. There's patterns of gene expression for the skin, for the lung, and for the placenta that you can identify. So if we wanted to, we could take amniotic fluid and run mRNA on it and identify fetuses that may be mature versus may not. In other words, a version of the old LS ratio that nobody does anymore, and then only treat fetuses that benefit. That test isn't available or ready yet. So there's some residual questions. Can we identify the patients who will actually benefit? What is the efficacy and the risk of antenatal steroids in low and middle income countries? I can tell you there's a paper in press done by the WHO and the Gates Foundation showing that in high, doesn't show anything very new. It shows that in high resource environments, so at the best hospitals in Buenos Aires or in Santiago or in any of these places, that steroids actually work in those environments. But if you take it into the outlying clinics, we still have no data to say that that's a good thing to do. Will lower doses decrease risk? We don't actually know that. That needs to be studied, and there's actually a trial being designed. How best to identify only pregnancies that will benefit? We don't know how to do that yet. We need a neonatology trial of RCTs in low and middle income countries in low resource environments. We do not actually know the fetal levels that are minimal to get a good response in the human. The published cord values suggest about 1 nanogram per milliliter. It's 1 nanogram per milliliter in sheep and 1 nanogram per milliliter in the macaque. So if you think about the biology of convergence and what word do I want? Darwood, it's unlikely to be an artifact. So the value of about 1 nanogram per milliliter in the human is probably a good estimate. Thanks very much. I hope you, so my take-home messages are we're treating a lot of women with the wrong dose of the wrong drug because the betamethasone sits around all the time in the women and so continues to treat the babies. So these babies are treated for weeks after their 2-dose treatment in the woman. So our babies are already being treated at the time they're delivered with a potent steroid, much more potent than hydrocortisone. And we can't identify who's who. So we're using the wrong drug at the wrong dose, at way too high a dose. And so I don't want to tell you to start using a lower dose until it's actually trialed and we know that it actually works. So at any rate, thank you for listening, and I ran through that faster than I should have. I should have talked a lot slower, but at any rate, thanks very much.
Muchas gracias, Alan, por la excelente exposición. La verdad que genera dudas, preguntas. Sospechamos que por ahí se está utilizando en demasía los corticoides prenatales. Hay un uso y un abuso de los mismos.
Thank you very much for this amazing presentation. It brings up questions and doubt about the use of prenatal steroids that we seem to be using them in excess.
Nos acompañan como integrantes del panel reactivo, a quien quiero pedirles que abran micrófonos y cámaras. La doctora Ana del Carreto, médica coordinadora de obstetricia del Sanatorio de la Trinidad Palermo.
We are being joined by our panel of experts by Dr. Del Carreto, who is médica, me repite, Dr. Di Gregorio.
Coordinadora de obstetricia.
She is the obstetric OB coordinator of Trinidad Maternity Hospital.
El doctor José Luis Díaz Roseló, miembro del CLAP, que es el Centro Latinoamericano de Perinatología, Salud de la Mujer y Reproductiva, que acaba de cumplir 50 años de vida.
The Dr. Díaz Roseló, who is the director of CLAB, ¿a qué se refiere CLAB de nuevo, doctor Di Gregorio?
Latin American Perinatal Center.
Okay. Thank you.
Y también el doctor Lucas Otaño, jefe de obstetricia del Hospital Italiano de Buenos Aires, experto en embarazo de alto riesgo.
And Dr. Otaño, who is a medical director of the OB department at the Italian Hospital in Buenos Aires.
Como les adelanté, la traducción va a necesitar que hagamos stop cada 2 frases o una frase para lograr una mejor conexión con el doctor Alan Jobe.
As I mentioned before, please make a stop after 1 or 2 sentences so we can adequately communicate with Dr. Jobe.
A los moderadores y al público, les pido por favor que, mejor dicho al público, que envíen a través del chat la dirección de mail, por si no estuviéramos a tiempo de contestar todas las preguntas en directo y las podamos contestar luego a través de esa vía.
Please to all members, can you write your email on the chat so if you have more questions that were unanswered because of the time, we can email you back the question and the answer.
Los panelistas ahora tienen el micrófono abierto para iniciar el debate.
Okay, so now the experts panel can start discussing the ideas.
Okay, let's go.
Bueno, comencemos.
Bueno, buenas tardes. Soy Andrea del Carreto. Primero, muchísimas gracias por esta invitación. Para mí es un honor haber recibido esta invitación y además un placer poder escucharlo, doctor.
Good afternoon. My name is Andrea del Carreto. Thank you very much. It's been a pleasure and really a pleasure to be here and listen to you, Dr. Jobe.
I'd much rather be in Buenos Aires, I can promise you.
Me preferiría mucho más estar en Buenos Aires, te lo aseguro.
Bueno, después de escucharlo me deja pensando mucho en cuánto tenemos que revisar nuestros procesos para intentar minimizar el uso de esteroides antenatales, después de todo lo que nos ha presentado.
After listening to you, I really kept thinking about how we should actually revise our protocols of delivering prenatal steroids after this talk.
Sobre todo en estos niños que ha dado de llamar expretérmino, ¿no? Que son pretérminos en algún momento, pero nacen finalmente de término o near term.
Specifically in those babies that are, we think they are going to be born preterm, but then reach term gestation, specifically those babies.
Well, so the problem here is a historical problem. And that's that Montliggins came up with a dose arbitrarily in 1972. And no one ever studied the pharmacokinetics and pharmacodynamics of these drugs in pregnant women. And none of this is regulated. It's not regulated by the FDA or anybody else. So people are just using around the world different doses by different routes. And it turns out that when you look at the animal model data, that we're using way too much drug. And we're still doing these studies to try to figure out exactly what the the best minimal dose is. But the only way we can get any information on the human is by measuring it in cord blood, of course, once the baby's born. And I can't, in all honesty, make recommendations about how we should dose because, you know, without having a trial to prove that it works at low dose, it does work. So we don't want to put kids at risk by not giving them steroids. But I can tell you that as we speak, the WHO and the Gates Foundation are designing a trial of low dose steroids using dexamethasone only, maternal IM, to see if it works in a low dose strategy. But of course, it'll take a number of years before that information is available. And unfortunately, we're treating all these kids that may have some adverse effects. So there's a publication that's available now from the WHO and the Gates Foundation, where they gave
Alan, can you stop so he can translate a little bit and then you go on?
Okay, Gaston, go for it.
All right. Entonces, esto es un problema histórico desde 1972, donde el primer científico que publicó estos resultados de corticoides prenatales lo hizo con dosis arbitrarias, completamente arbitrarias, sin estudios farmacológicos y farmacokinéticos que después lo siguieron estudiando, y todos adoptamos la modalidad y la terapéutica en base a ese primer estudio. Y en los modelos animales que estamos haciendo nosotros vemos que estamos en realidad usando mucho nivel de droga. Entonces tenemos que seguir investigando en los modelos animales. Yo no puedo hacer recomendaciones de cómo usarlo o de con qué dosis usarlo sin haber antes un ensayo clínico en humanos. Pero sí quiero dejar en claro que también son muy buenos los corticoides, así que no me atrevería a parar porque ayudan con muchos bebés pretérminos. En este momento la Organización Mundial de la Salud y la Fundación Gates están diseñando un estudio usando dexametasona solamente para ver si sirve en niveles bajos, pero desafortunadamente los resultados de este estudio van a estar recién en muchos años. I think that was all. Esto creo que es todo lo que dijo. You can continue, Dr. Jobe.
So the trial, there is a trial published in the New England Journal. It's online. It's not in paper yet, where they gave, these are pregnancies in India, Pakistan, Kenya, and Nigeria, where they randomized women to either 6 milligrams of dexamethasone or placebo. It's actually a placebo-controlled trial. And they found that there was an effect of the 6 milligram dose is the WHO recommended dosing scheme. So it's this big dose. And it does have an effect, but it's sort of interesting. Nobody discussed it in the paper. If you look at the meta-analysis that were done for the studies in the 70s, 80s, and early 90s, the magnitude of the effect, the risk ratio was about 0.6 for death. And in this new trial, the risk ratio is about 0.8, which means that the steroids are far less effective than they were 20 years ago. And that's probably because if death is your outcome, we as clinicians are better able to take care of babies with RDS so they don't die. So, any rate.
Okay, so entonces realmente ahora hay un ensayo en New England Journal of Medicine que se puede leer, que no está oficialmente publicado, eso entendí yo, pero se puede encontrar de embarazadas en India, Pakistán, Kenia y Nigeria, donde randomizaron a mujeres para tener o placebo o recibir 6 miligramos de dexametasona. Y vieron que había un efecto de la dosis de 6 miligramos, como recomienda la Organización Mundial de la Salud, un efecto positivo para bajar el odds ratio de muerte de 0.8, que a comparación de los primeros estudios que bajaban la muerte a un odds ratio de 0.6, el efecto de prevenir la muerte es menor. Y lo que creo es que es porque ahora estamos mucho mejor en prevenir la muerte por el tratamiento postnatal del síndrome de distrés respiratorio del prematuro, y así entonces el efecto de los esteroides no es tan marcado como en otros estudios anteriores. You can continue, Joe.
So is there another question?
¿Hay alguna otra pregunta?
No, creo que nos queda mucho por trabajar para mejorar nosotros los obstetras la selección de los pacientes a tratar, independientemente de la dosis que vayamos a utilizar en el futuro después de los ensayos, ¿no? Que por suerte
we
vamos
have a lot of work to do from our obstetric point of view to carefully select those patients that will receive the treatment and those who should not.
So what is being used in Argentina? Is it dexamethasone or is it the celestone product? The two
¿Qué es lo
components.
que está usando en Argentina? ¿Celestone o dexametasona?
Celestone, beta.
beta, combinación, betametasona.
It's celestone.
Okay, so the issue with the celestone is that the betamethasone acetate is actually particulate. And so when you give the mother an injection, you actually form a depot. And so you're getting a very slow release of that stuff from the mother. And that's the problem with that drug. So, I mean, I think it's safer to use dexamethasone. It's cheaper and it's doesn't cause the prolonged exposure. But you have to give 4 shots. Actually, you don't. You can give it orally, based on the studies we did in India.
Entonces,
but that's never been tested. That's never been tested clinically either.
Gastón, decirle que nosotros igual usamos una cosa que se llama celestone crono 12, que tiene las dos, la de depósito y la de acción rápida.
So we actually use celestone, a type of celestone that has both type of steroids, the one with rapid release and with the one with a slower release.
Okay, well, the only one we have has the 2 components.
Yes, the same. It's the same that we use here.
Entonces, en la respuesta a lo anterior, el problema con el celestón es que tiene betametasona, acetato de betametasona particulado que se queda en un depósito, como el doctor Otaño mencionó, y que tiene una liberación a la madre de forma muy lenta y por muchos días. Y yo me siento más seguro usando dexametasona, que a pesar de que son más inyecciones, tiene el efecto más concentrado y en más pocos días.
Lucas o el doctor Díaz Roseló, ¿algún comentario al respecto?
No sé si... Sí, bien. Yo quería compartir con el doctor Jobe la situación en algunos países de América Latina. ¿Quieren que haga la traducción yo? ¿Hago simultáneo?
I would like to share with you some of the situations in some of the countries in South America.
Okay.
Okay.
Desde 1978, el Centro Latinoamericano de Perinatología promovió el uso de corticoides. No había ventilación, no había surfactante, no había enfermería y había un alto componente de muerte neonatal por distrés respiratorio. Coco, ¿preferís que lo diga yo?
Since 1978, the Latin American Center of Neonatology, we have promoted and pushed the use of corticosteroids because there was no advanced ventilation, there was no advanced trained nursing, ¿qué más? Aparte de enfermería, ¿me podría repetir, doctor Díaz Roset?
Deja que lo hago. And what I expect, at that time, 20 to 30% of all neonatal deaths were because of RDS. So there was no other choice to start preventing the RDS, as most of the trials has started to show. We started very early, 1978. Ahora, cambiamos del 78 al 2000, la mortalidad neonatal bajó. Would you like to say it?
So since 1978, when we started using prenatal steroids early, the mortality on RDS was very high, and this was the only option we had. But since then, the mortality has decreased.
I think that's true. The whole issue is that we've never really studied this drug to figure out how to optimally use it. So that at the end of the day, I believe what you say, and I think you did the right thing. The problem is that we're using way too high a dose. The dose we're using is actually the same dose, essentially, that they use in the COVID patients who are getting corticosteroids, dexamethasone, to try to save their life. So it's a big dose. It's far and away above any dose that's used in general clinical medicine. 24 milligrams is just a hell of a lot of drug. But I don't think we can safely decrease it because we don't have the trials to prove that it works at a lower dose.
Okay, hold on a second, Alan. Gastón.
Entonces, estoy completamente de acuerdo de que esto fue algo certero, que usar corticoides prenatales para prevenir la enfermedad de los bebés es algo certero, pero creo que las estamos usando con una dosis muy demasiado alta. Es la misma dosis que se usa en pacientes con coronavirus para salvarles la vida si están extremadamente enfermos. 24 miligramos es demasiado alto. Okay, continue.
El punto es claro y usted lo hizo muy claro y le agradecemos. El siglo XXI, menos es más.
The point that you make is quite clear, and we thank you very much for remarking that. And really, in this century, more is less. I'm sorry, the other way around, less is more.
Yeah, well, that's been a problem for obstetrics and neonatology historically. We don't know how much of the drugs we use, and we don't use them with enough information. The studies we've been doing in animals should have been done 40 years ago.
Este es un problema muy común en obstetricia y neonatología con todas las drogas que usamos. Los estudios en animales que les mostré tendrían que haberse hecho 20 años atrás, no ahora.
El problema que heredamos del siglo pasado es que, a diferencia de Finlandia, en el estudio de Räikkönen, nosotros tenemos 16% de corticoides antenatales en los embarazos que llegan a término, y el estudio de Räikkönen tiene solo un 1%. Tenemos 16 veces más corticoides en el término que en el estudio de Räikkönen. Sorprende que el estudio de Räikkönen... Dilo.
The big difference that I'm noticing is, and I'm concerned about, is that the Räikkönen study from Finland shows that compared to that, we in Argentina have, or in Latin America, have 16% of babies that reach term gestation that have been exposed to prenatal steroids, compared to the 1% that the Finland study shows.
Well, that's so you're doing. I mean, you're exposed. I think in the U.S. I have no idea what the number is that is exposed that deliver at term. We don't have that information that I'm aware of. So, I mean, I think it's something that we have to worry about. You know, I don't quite know how to deal with it. The problem is that all of these things, the follow-up studies to detect these phenomena can only be done in Scandinavia. They can't be done in the US or in South America, where nobody's following up their kids with systematic neurodevelopmental studies.
En Estados Unidos no tenemos información que yo sepa acerca de estos datos. Creo que es algo que tenemos que preocuparnos definitivamente. El problema es que estos estudios de seguimiento de neurodesarrollo solo se pueden hacer con el sistema que tienen en Escandinavia y no en Estados Unidos o en Latinoamérica.
Termino mi comentario diciendo que la era digital nos lo va a permitir, porque en América Latina, en Argentina, en Uruguay, en Bolivia, en Nicaragua, los registros perinatales tienen identificador de identidad, y perfectamente en un futuro se va a poder vincular los registros perinatales con los registros de desarrollo o de rendimiento escolar.
I end my comment with...
Ese es un desafío.
I am saying that hopefully in the digital era, we will be able to do this better because in Latin America, for example, the perinatal registries that we have are gathering birth identities or registrations that we hopefully will be able to match and link with school performance and so on.
That would be great.
Eso sería genial.
Thank you. Muchas gracias, doctor.
Thank you. Thanks for your comments.
Gracias por tus comentarios.
Bueno, pregunto. Bueno, muchas gracias, doctor Jobe, excepcional. Y yo me anoté como 20 preguntas, pero voy a hacer solo 2 o 3. Pero me voy a referir a una frase introductoria que me gustó, que para bien o para mal, los obstetras son los que indican los corticoides. Y yo les quería contar que en la Argentina, o por lo menos en nuestra región, en los últimos 48 años, los obstetras indicamos corticoides porque nos presionan los neonatólogos.
So, thank you very much for this exceptional talk. I wrote down 20 questions, but I think I'm going to stick to a few. And first of all, I want to remark what you said on your introduction, that for good or for worse, the obstetricians are the ones that prescribe the prenatal steroids. And let me tell you that here in Argentina, we do it because of pressure of the neonatologist.
Okay.
And that's fine. I mean, you know, I think I think I'm in an awkward position because I think the reality is that we're using the drug incorrectly, but the drug is effective, so we should continue to use it until we know how to use it better.
Muy bueno.
Eso está bien, pero creo que estoy en un lugar incómodo porque les estoy hablando de que estamos usando la medicación de forma incorrecta, pero que todavía la tenemos que seguir usando hasta que demostremos que podemos hacerlo mejor.
Pregunta práctica para empezar a hacer mañana. ¿Debiéramos cambiar la betametasona por dexametasona a la luz de los conocimientos? Y dado que está aceptado cualquiera de las dos, todos los que estamos usando betametasona, ¿debiéramos cambiar para dexa mañana mismo?
A practical quick question. Should we change based on the findings that you show us and based on what everyone is using? Should we change our use of betametasone for dexamethasone?
Well, I think that's a reasonable thing to do because there are now 2 studies, the one in the New England Journal that's in press, saying that the dexamethasone regime works. And there's a comparative trial that was published about a year ago comparing celestone with dexamethasone, and the outcome was identical. So I think it's safe to switch to 6 milligrams of dexamethasone every 12 hours. And the thing about it is that the half-life of the dexamethasone is quite short. So you will not have as many, you won't expose the fetus for a prolonged period of time to the steroid. And the other advantage is it's very cheap.
And you can do it orally.
Well, the problem with the oral is that's never been tested clinically either.
Okay.
So theoretically, if I were to switch, I'd give it IM because there's 2 studies that say that works.
Bueno, en respuesta a si tendríamos que cambiar de betametasona a dexametasona, bueno, es algo razonable de hacer porque ahora hay 2 estudios ya, el que les comenté del New England Journal of Medicine que está en prensa y otro estudio comparativo que comparó celestone con dexametasona y el outcome o el fin del estudio fue idéntico, que creo que es seguro cambiar de betametasona a dexametasona de 6 miligramos cada 12 horas, y lo bueno es que la vida media de dexametasona es más corta y no van a exponer al feto a muchos días de la droga, y la otra ventaja que es barato. Con el comentario respecto al uso de vía oral de dexametasona, el problema es que no han habido estudios suficientes para validar ese uso.
And the other reason to think about if you're going to switch to go to dexamethasone is that's the recommended treatment by the WHO. So it gives you some sort of legal coverage in terms of saying, well, we're using an accepted dose.
Y la última razón para cambiar es que este es el tratamiento que recomienda la Organización Mundial de la Salud y les da un seguro legal o un respaldo legal de que estamos usando tratamientos que están recomendados por ellos.
La segunda pregunta es, por motivos que seguramente tienen que ver también con el uso liberal de corticoides, hemos dejado de hacer en nuestro medio amniocentesis para evaluar madurez fetal. A la luz de todo lo que nos dijo, ¿debiéramos volver para atrás y debiéramos chequear madurez en líquido amniótico antes de indicar corticoides después de las 31 o 32 semanas?
So my second question, and this is probably for reasons that we have used steroids more liberally, is that we have stopped measuring fetal lung maturation by amniocentesis. Based on what you showed us, should we think about checking lung maturation even before giving corticosteroids?
Well, I mean, I think that's an interesting idea. The problem is that you're not the only ones that doesn't do lung maturation testing anymore. Virtually nobody does it in the US anymore. And so I'm not an obstetrician, so I hate to make recommendations. But I mean, there's some risk to an amniocentesis. So I think if the trade-off is you think you need steroids because the woman is preterm and you don't want to get into doing amniocentesis, I would probably just give the steroids. I mean, the future here is that the Gates Foundation is interested in is being able to take maternal blood and measure gestational age accurately without using ultrasound based on whatever is in the maternal blood that is generated, which will indicate gestational age. We don't know what that is yet. And at the same time, you could theoretically measure something that would tell you about lung maturation. The problem is none of that's available. It may be in 15 years. But then at that point, you could actually selectively treat only babies that would benefit from the antenatal steroids, which would be the perfect solution.
En la última, no, dale Gastón.
Es muy interesante esa idea de empezar a hacer amniocentesis para evaluar maduración fetal. El problema es que ustedes no son los únicos que ya la dejaron de hacer hace mucho tiempo en referencia a la amniocentesis. En Estados Unidos nadie la está haciendo ya. Entonces, yo no soy obstetra, así que no me gustaría hacer recomendaciones con respecto al manejo obstétrico, pero hay riesgo de amniocentesis, así que me inclinaría a igualmente dar corticosteroides sobre hacer la amniocentesis. La Fundación Gates en el futuro, y a esto queremos llegar, es que quiere evaluar la sangre materna y medir la edad gestacional y la maduración pulmonar, en vez de hacerlo todo por ultrasonido o otros métodos diagnósticos. No sabemos qué van a medir y cuándo se va a hacer esto, y al mismo tiempo, en ese momento, al llegar a ese método diagnóstico, podríamos darle la medicación a aquellos que se beneficiarían y no a todos.
Y la última pregunta, a la luz de lo que dijo, ¿deberíamos dejar de dar corticoides post 37 semanas, post 36, post 34? Si le parece, ¿está de acuerdo con eso?
Disculpe, doctor Octaño, dijo post 34, post 36.
Y post 37.
Post 37. Dr. Jobe, based on what you just mentioned, should we then stop giving corticosteroids after 34 weeks, after 36 weeks, and after 37 weeks?
Again, I'm not an obstetrician, so the thing is that the data on benefit for the late preterm gestations is such that the benefit is quite modest in terms of RDS and those sorts of things. And there are some downsides like the hypoglycemia. So I would probably not be giving it beyond, pick a number based on your own clinical experience, beyond, 35 weeks or something like that.
De nuevo, no soy obstetra, pero los datos del beneficio de los corticosteroides en pretérminos tardíos, el beneficio es muy modesto en términos del distrés respiratorio del recién nacido y otras cosas más. Y hay también desventajas como la hipoglucemia, así que yo preferiría no darlo en términos tardíos y en general por arriba de 35 semanas no darlo.
Perdón, vamos a darle la palabra a Pamela Contreras. La doctora Pamela Contreras tiene una pregunta del público, creo que del doctor Mario Sebastiani. Gracias, Pamela.
Hola, ¿cómo están? Sí, bueno, con respecto a los corticoides, le pregunta el doctor Sebastiani, ¿los efectos indeseables de los corticoides pueden traer problemas legales? Sería que sí. ¿Qué sucede con los chicos que le damos corticoides y nacen de términos, y en aquellos chicos que le damos corticoides una dosis y nacen prematuros y tienen una enfermedad pulmonar más grave?
So
Y eso trae problemas.
Is it possible to have legal consequences of giving steroids on babies that are born at term, or on the other hand, to give steroids to, doctora Corteras dijo, a un bebé que con una sola dosis tiene...
No, bueno, lo que quiso decir Gastón es si se dan una dosis más baja porque decidimos cambiar por los efectos colaterales, si esto nos puede traer problemas legales en un chico que igual tenga distrés respiratorio.
So if we consider to give a lower dose of corticosteroids, and then we see that the pulmonary disease of the baby is worse, is it possible to then have legal consequences based on that?
I'm no expert on the lawyers in Argentina, but the problem is it looks like, as best we understand it, either you respond to steroids or you don't respond. You don't get partial responses. And in terms of these effects on the babies that deliver at term, those are very late effects. They're not really detected until the kids are 6 or 8 or 10 years of age. So it's probably not a problem. I mean, theoretically it could be, but nobody's going to track them to actually figure out what that association is.
Entonces, no soy un experto legal en Argentina, pero lo que le puedo decir es que hay bebés que son respondedores y hay bebés que son no respondedores, y eso es lo que estamos viendo en los experimentos con animales. No hay una respuesta parcial a la medicación. Y con respecto a los bebés que recibieron corticosteroides y nacieron a término, no hay un efecto al corto plazo, los efectos son más tardíos, cuando los bebés ya tienen 8 o los niños tienen más 8 y 10 años. Entonces, me parece poco probable que alguien traquee o junte esos dos eventos con tanto tiempo.
Perfecto. La doctora... perdón, doctor, adelante.
Doctor Jobe, hay un tema que no está en la agenda de los corticoides, que es la vinculación entre toxoplasmosis y terapia esteroidea. ¿Quieres traducir?
Sí. So there's something that is not often discussed, which is the impact of, or the link between toxoplasmosis and corticosteroid treatment.
I don't know anything about that.
En América Latina y en el sur tenemos 40% de mujeres que ingresan habiendo sido pacientes con toxoplasmosis asintomática, y un 60% están en riesgo de adquirirla durante el embarazo. Y el efecto en los animales de experimentación y en los inmunosuprimidos cuando se les da corticoides es que la severidad de la enfermedad aumenta. Eso nunca fue estudiado, es una enfermedad parasitaria que por lo tanto los corticoides la agravan.
So about 40% of women that are admitted to the hospital have had toxoplasmosis that has been asymptomatic. And up to 60% of these women are at risk of acquiring new toxoplasmosis infection during pregnancy. And what we know from animal studies and from immunosuppressed population is that the combination of corticosteroids and the infection of can aggravate or worsen the severity of toxoplasmosis.
Again, I don't know anything about that, but you could make the same argument probably for tuberculosis. And I don't have any idea about Chagas disease, which is something you have down there, how that interacts with steroids. I have just no information at all.
Bueno, de nuevo yo no sé mucho de esto, y la misma pregunta y preocupación se podría hacer de tuberculosis y también de Chagas, que ustedes tienen mucho en Latinoamérica.
Bueno, es un lujo, estaríamos un rato largo. Queda una pregunta del público, lo va a llevar adelante la doctora Florencia Schiaretti, pero ya estamos sobre el límite del tiempo y también lo tenemos que dejar descansar a Alan.
It has been a luxury. This is the last question by Florencia Schiaretti, and we promise that we will let you rest after this.
Okay, that's fine.
Okay,
Buenas tardes.
I need a big steak and a Malbec.
Necesito un gran asado.
Y un Malbec, y un Malbec.
La doctora Navarro pregunta, un prematuro que recibe corticoides prenatales y luego nace a término, ¿va a tener problemas en el neurodesarrollo?
The question is whether what kind of neurodevelopmental problems can a baby that is born at term and receive corticosteroids have?
Well, it turns out that the fins do a whole battery of tests, and so a lot of these things are related to learning and reading and math and all sorts of sort of subtle neurologic things. It's not like they have something horrible like seizures. It's all subtle findings that are actually normal variants of what people see in childhood. So it's a little hard to get your head around exactly what these problems are. And, attention deficit defects and things like that, which are clearly a problem. I'm not saying that they're not important, but the problem is they're not what you call hard neurologic findings like stroke or seizures or something like that. They're subtle behavioral and developmental problems. You can look at the paper and you can see the variation of stuff they measure. They measure an incredible amount of stuff in Scandinavia on their kids. And the rest of us in the world don't do that at all because they have a socialized healthcare system, single payer. That's what we ought to have in the United States.
Los finlandeses tienen un sistema social que hacen que puedan medir cosas muy detalladas y hacer muchas evaluaciones, incluyendo matemática, cosas sutiles como atención o déficit de atención, que no son problemas neurológicos severos como convulsiones o problemas de movilidad, son problemas que tiene la población general, que siguen siendo problemas, pero no son problemas neurológicos severos. Y ellos lo pueden hacer porque tienen este sistema de control por medicina social.
Bueno, muchas gracias de nuevo a todos. Alan, muchísimas gracias, infinitamente agradecidos por la excelente charla. Gracias, Gastón, por la traducción, y gracias a los panelistas y a los colegas del público que hicieron preguntas muy interesantes. En 3 a 5 minutos nos volveremos a encontrar. Lo dejo con el final de la traducción a Gastón. Muchas gracias.
Well, thank you, Dr. Jobe. Infinite thanks to all, to you and to your wisdom, and to all the expert panel. And we will meet again in a few minutes. Thank you very much.
So, Gaston, you're going to become a cowboy?
Si voy a ser un vaquero porque estoy en el sur de Estados Unidos. Yes. This is natural in Kentucky. This is a natural outfit for me, obviously.
Para los que no saben, Gastón fue convocado como médico de planta en Oklahoma y hoy hablábamos sobre nuestras preferencias de dónde elegiríamos vivir y no hubo mucha gente que votara por Oklahoma, pero ¿qué va a ser, Gastón? Te queremos igual. Okay, thank you very much, Alan, and we will have a 5 minutes break, and you are free to get your Malbec if you have one at home.
Of course I have one at home.
Okay. Bueno, muchas gracias a todos. En 5 minutos me tienen que aguantar a mí los que se animan a quedarse.